Hello and welcome to another intensivecarehotline.com and intensivecareathome.com live stream. First off, Merry Christmas to you and your families. And I believe if you're watching this, you might have a loved one in intensive care during the festive season, which is not a joy. You know, I'm sure you would like to spend time at home with your families rather than worrying about having a loved one in intensive care. But rest assured, me and my team, we are here to help you even over the festive season and the new year. You know, we know how difficult it is managing, the fears around having a loved one in intensive care. So please rest assured that we are here to help you even over the holidays. Now, before we go to today's questions, thanks again for coming onto the show. Thanks for your support. If you like what I'm doing here, please subscribe to my YouTube channel, give the video a like, click the notifications bell, share the videos with your friends and families, and comment, of course, what questions you have and what insights you have from this video. Now, before we go into today's questions, want to also thank you, the viewers who watch this on replay. I usually do these YouTube lives once a week on a Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is 6:30 p.m. Eastern time on a Saturday in the US, which is 3:30 p.m. Pacific time on a Saturday in the US. Now, what makes me qualified to answer questions for families in intensive care? I'm a critical care nurse by background. I have worked in intensive care / critical care for over 20 years in 3 different countries, where I also worked as a nurse unit manager for over 5 years, and I have been consulting and advocating for families in intensive care for the last 10 years as part of my intensivecarehotline.com consulting and advocacy service. I'm also the managing and founding director of Intensive Care at Home. You can find more information at intensivecareathome.com. With Intensive Care at Home, we are sending critical care nurses into the home, predominantly for long-term ventilated adults and children with tracheostomies, but also for adults and children that are not ventilated but have a tracheostomy, for adults and children that don't have a tracheostomy but are BiPAP or CPAP ventilated. Also, we provide home TPN, home IV potassium infusions, home IV magnesium infusions, home IV antibiotics. We manage central lines, PICC lines, Hickman's lines, and port catheters at home. And we also provide palliative care at home. Now, that's enough about me. Maria says, hello, thank you for this chat. Yeah, you're welcome, Maria. Please type your questions into the chat pad, or anyone on this call, please type your questions into the chat pad. Or if you want to join me on this call and you want to talk to me directly here, use this link that I'm just posting into the chat pad. Please use this StreamYard link and you can come live on the show. You can go on camera, talk to me, or if you don't want to go on camera and talk to me, that's fine too. I welcome you to do that. And if you don't want to talk to me directly, just type your questions into the chat pad and I will get to them. Now, without further ado, let's look at some of the questions that have come in this week or last week. There's so many of them. Let's just get started with the first one, which has come from Rena, who says, hi Patrik, thank you so much for your website. The hospital didn't tell us that my dad's liver was lacerated during a gallbladder removal surgery. He ended up having sepsis and pneumonia after that. He was placed in an area for COVID patients, but we were not told. They would tell us they were treating the sepsis and the pneumonia. He was given fentanyl, but he didn't know what it was until I researched it. The hospital kept asking for permission over the phone to do more procedures. sometimes saying when he gets better, we can remove this or that. They knew he was not going to get better. They knew he was dying. My family was devastated, distraught, to say the least, from Rin. Right. Well, that's very sad to hear. I guess, the first thing that I would like to comment here on is, Victoria, I can see you. I'll get you in a second. I'll just answer that question, then I'll let you in. So the first thing that I will say is, once again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And that's exactly, once again, what you are dealing with here, Reen, because you haven't had access to the medical records by the sounds of things. That's the first thing that I would recommend, that you get access to the medical records. And if you don't know, what procedures they're doing, again, that's when you need consulting and advocacy, a second opinion, someone that can guide you step by step, because it sounds to me like it's too late. It sounds to me like your dad has passed away, and that's no good, because that might have been avoided if you have sought help early on. The least that we can do for you now is look at the medical record. So please reach out to us, Rain, at intensivecarehotline.com, and send us an email to support@intensivecarehotline.com, or call us on one of the numbers on the top of our website. So that's very sad, Rain, to hear that. Okay, Victoria, I'll just let you in. Just give me a second.
Can you hear me?
I can hear you. Thank you so much. Can you hear me?
Oh, I hear you fine. Thank you so much. Happy holidays.
Same to you, Victoria, and thank you for coming.
Thank you. It's
onto
the first
call.
time. I want to say thank you so much for this wonderful service. And I have received your ebook. But I'm going to tell you something. We're ahead of the game with this ICU situation. Just to give you a brief overview, my mother sustained a fall at her skilled nursing facility. She went into cardiac arrest, was rushed to the hospital. They brought her back. She was resuscitated. And so she's been in ICU since November 1st, 2nd. She was breathing on her own for a few, I guess for a little bit, 5 hours, I was told. And then she went on a ventilator. And she's been on a ventilator since. And we've had the infamous family meetings. However, they weren't prepared for what I hit them with, because I'm a research guru by nature. And so I have looked up all of Mom's ailments. She's 92 years old. I've looked up all of her ailments. I have access to medical dictionaries here at the house, Mosby, Merck, Principles of Internal Medicine, Harrison's. And so I started to delve into this stuff. And first I sat down with a neurologist who he didn't know I was taking notes, but he said several different things, different times that he met with me, and I recorded them. I didn't say anything. I just kind of let him talk. And then I started asking some questions, and then I started pulling out my resources. And then he had a difficult time trying to refute those sources. So I haven't met with him since.
He's trying to avoid you. He's trying to avoid you.
Then we had the case manager who was going to send my mother off to another location in hospice. And I said, but she's not 6 months. Hospice is for sick people 6 months to live. Right now, when I walk in her room, she's got a heartbeat. She's got a pulse. She's got strong vitals. I said, why would we want to take that away? And my father is on the call also. And he says, if you don't know what's wrong with my wife, what's the problem here? He says, and what are you going to do about it? So he pushed them up against the wall to the point where, let's just say he's a retired police officer. He knows how to do those things, to the point where they said, I don't know. And then finally, the last conversation I had was with a social worker the other day. And I totally exploded. I said, this hospital that you all advertise on TV is supposed to be the best in the region. I says, I don't know is not an acceptable answer. I said, you cannot. I says, first of all, I've narrowed this down to two areas of where she has a problem. She has a problem being able to breathe without a ventilator. That's one problem. I says, and the other problem is we're dealing with a consciousness issue. She's not waking up. I said, let's deal with these two issues first. And I said, and I'm tired of talking to physician's assistants who think they're doctors. And I said, and oh, by the way, let me tell you something. I said, I think you all need to train them differently. I says, I'm in the state of Connecticut. I says, and our laws here in the state, the Connecticut General Statutes, is clear about what physician's assistants can do and cannot do. You've got some of these people that are doling out, first of all, in their mind, mentally, they think they're doctors. And number two, they're doling out information that legally they're not even supposed to be doing because they're working under a physician's license and the rules of the hospital. I said, I don't want to talk to them anymore. These are doctor level conversations. And my dad was sitting there and he said, absolutely. He said, we are not getting 8 people in the room to talk about the care of one woman. Out of the question. And so we've halted those meetings. Interestingly, since I went off on that tirade, and I told him, I said, no is not an acceptable answer. I don't know is not an acceptable answer. I said, it can be, I don't know, but here's where we're going to investigate further. I says, when you don't bring in specialists and you've got people there who are seasoned professionals and you don't bring them in, that's a problem. I says, and that's not good. So I said, we're not talking to these physician's assistants anymore. We're talking to the doctors. So the head of ICU came in to see me a couple of days ago. Very nice gentleman. But I said to him, I said, look, this is where we're at. I said, my father is vehemently opposed to having a tracheostomy on my mother. I said, and he is not interested in doing that because of the problems that it poses. And in addition to the problems being posed, okay, you're going to dismantle this stuff and put her in hospice? I says, and then that's the end of her. I says, no, unacceptable. And I said, and I'm pretty sure that I said, we have to concentrate on waking her up and also getting her off the ventilator. I says, and it has to be done in the most uninvasive way. So he said, I said, there's got to be, I said, there's something going on in the brain. I said, so we need to bring in some neurologists involved. And I says, I'm just not talking about any neurologist. I says, I need top people, seasoned people that can look at this and say, here's the problem. Have you checked here? Have you checked there? Okay. And then I also talked about the consciousness. And he said, well, there are things we can do to wake her up. And I said, well, okay. I says, that's fine. That's fine. I said, but the biggest thing is the ventilator now. I said, that's the big piece. So then they brought another doctor in who's on this week. And he and I had a conversation today. She's now experiencing a UTI infection. They're treating that with vancomycin and cefepime. There may be MRSA, but we're not quite sure. The doctor thinks it may be pneumonia. She already had another bout of that, but I'm not concerned about that right now because they've introduced the medicines very quickly. I check her every day. There's something called Follow My Chart. And so I see every test that is being done, every blood test, everything that's done. They poke her, I know what's going on. So I tell the nurses and I tell the doctor, I said, listen, I know exactly what's happening. I get an alert every time on my phone. What's happening here? What does this mean? What does that mean? Okay. And so now that I've given you the whole story, the piece now, the doctor wants to talk again, is about this tracheostomy. I asked him point blank, and I knew this before I asked the question because I had looked at your channel and I had done my own research. I said, what are some alternatives to tracheostomies? And he looked me right in my face and said, there are none. And I knew that was a lie. And so we're supposed to be having a conversation with him on Wednesday. And I think, again, this is another push. I said, listen, I said, she's got to be able to breathe on her own. Right now, she's on a ventilator now. That she was at 50 yesterday, a 50 setting. She's now at a 40 setting.
Are you talking about FiO2? Do you know what the 50 and 40 means?
Well, I don't know, but she's on a pressurized, what is that, PCAC, whatever that.
Yeah.
Yeah.
PCAC and 40 and look, the 40 and 50 probably means she's on 40% of FiO2, which probably means the oxygen they're delivering, most likely. Room air, the
Yes.
air that you and I are breathing, is 21%.
Mm-hmm.
So if she's on 50 or 40% of oxygen, that's double the amount of room air in terms of oxygen. Now, Victoria, just that I understand this 100%, she has been ventilated since the 2nd of November with a breathing tube in her mouth.
Yeah, I would say probably around that time. Maybe give or take a few days. I don't remember it being in immediately.
Okay. And why do you think she's not waking up?
Obviously, she's sedated.
Okay. So the first thing that stands out here, Victoria, is, you've shared a lot of what's going on, but the first thing that stands out to me is she needs a tracheostomy and get off sedation and wake up. She's been intubated for way too long.
Okay.
So if you look at some of my articles on the website, it says, day 10 to day 14, a tracheostomy should be done. One of the main goals to do a tracheostomy is to get rid of sedation. It's one of the main goals. And whilst I argue before you do a tracheostomy, they need to do everything beyond the shadow of a doubt to get off the breathing tube, one shouldn't wait longer than day 10 to day 14 to do the tracheostomy. If she can't be weaned off the ventilator,
that's what they were telling me. That's what they were telling me, is that she couldn't be weaned off.
That's what I would tell you. What sedation is she on?
I don't know. I think it's propofol. Propofol, yeah.
The side effects you're getting from sedation, and probably also opiates such as morphine or fentanyl, in the long run are worse than the side effects from a tracheostomy. Right?
So, okay.
Because, like I said, one of the main goals of a tracheostomy is stop sedation immediately. And then you can look at things such as mobilization, physical therapy,
That's what this new doctor is talking about. And so what I've done is I've said, okay, well, Wednesday, you need to have a conversation with my father about this. He said that the procedure could be done right at her bedside.
Can be. Yeah.
And so I didn't let on one way or the other, because I couldn't do it anyway, because my dad is her next of kin.
Yeah. Yes, so, I get that.
So the only thing that, and I said, well, okay, after we do that, she's still in ICU. For how long? Because I know the game is, let's get him out of the bed, get him out of ICU. And I'm in a place where, I think they've located, 2 facilities that could take her. One is about 20 minutes away, Hospital for Special Care in New Britain, Connecticut. The other is another one, and I understand that Gaylord in Wallingford has a ventilation weaning program, and that's a little bit further out. I know that Gaylord is very good. There was another one that I can't remember, but I wrote them down, and I know that,
So let's just look at what I would perceive is a best case scenario, and then maybe let's look at what I would perceive as a worst case scenario, and let's see how you can sort of achieve the best case scenario and avoid the worst case scenario. So let's just say your dad is happy to give consent to a trach. They will inevitably also ask you if you would want to give consent to a PEG tube.
That's what I heard about. Yeah, that has something to do with feeding, correct?
Correct. So at the moment, you would most likely have a nasogastric tube.
She has a what?
A nasogastric tube, a tube that goes up her nose into her stomach, and she's having nutrition through that.
This one is not going through the nose. This is going through the mouth.
Through the mouth. Okay, fair enough. Fair enough. Okay. So let's just say your dad is happy to give consent to a trach. In the same sentence, they will ask him, is he happy to give consent to a PEG tube? Now, here is what I've learned with PEG tubes over the years. The minute you give consent to a trach and a PEG, they are bait. A patient is bait for LTAC, right? Or for skilled nursing facilities, or, or for, you mentioned Gaylord, they would snap those patients up as quickly as possible because they deem them as quote unquote safe to look after them. Here is the problem. From what I've also learned, if you don't give consent to a PEG tube and you stick with a nasogastric tube instead, many LTACs can't take those patients. Right? So your stop to move her to LTAC after she had a trach is almost by not giving consent to a PEG tube. Do you know what a PEG tube would be? A surgical incision into her tummy, right, to put a feeding tube in there. Does that make sense?
Yes.
Right. So, as I said, if you don't give consent to a PEG tube, most of the time patients can't leave ICU. They can go within the hospital to a step-down ICU. They can do that, but they can't leave and go to LTAC most of the time. There are some LTACs out there, from what I gather. They can actually take a patient with a nasogastric tube instead of a PEG tube, but it's not the norm.
When you say ALTEC, what is ALTEC? What does that mean?
Long-term acute care.
Okay, long-term acute care. Okay.
And when you say Gaylord, what did you say about Gaylord? It's a respiratory rehabilitation.
Yeah, they have on their website, they have a ventilation weaning program. Although I found that out on my own. The hospital didn't tell me about that.
I see.
I found that out by consulting with the University of Connecticut Medical Library. I also do research, I contact their librarians via chat, and they've sent me information. It's been very helpful about ventilation weaning.
Okay. So here is what I would do then, Victoria, if I was you. So obviously they have been pushing for a tracheostomy.
Yes.
Ask them what's next after tracheostomy. Get it from the horse's mouth, so to speak. Ask them what's next, because that'll give you an indication. At this stage, they haven't mentioned LTAC yet, because as long as they can't do a tracheostomy, it's not even a point of concern for them. Ask them what's next.
Mm-hmm.
If your dad is happy to give consent to a trach. Here is and see whether they put their cards on the table, because I don't think they have. Don't think they put their cards on the table.
No.
So here is my concern, Victoria. So every day your mom stays sedated and in a coma because she's having the breathing tube, she's getting deconditioned, right?
Mm-hmm.
And this is why a tracheostomy, one of the goals of the tracheostomy is, once again, to wake patients up as quickly as possible, because unlike a breathing tube in the mouth, a tracheostomy doesn't really require any sedation. And therefore, you can start mobilizing people early, rebuilding their strength. So I would argue your mom has lost valuable time to rebuild her strength by being kept in a coma, if that makes sense.
Mm-hmm.
Right, especially at her age. It's critically important that you minimize sedation early on.
Yeah.
And get people moving as quickly as possible. Imagine someone confines you to bed, to a bed for weeks on ends. It would be terrible. And that's pretty much the situation your mom is in at the moment. Plus, she's getting a cocktail of propofol, probably some fentanyl or morphine,
No, not fentanyl or
Okay,
morphine.
good. Okay. And what happens if they wake her up? What happens? Have they tried that?
No, they've not tried waking her up.
Do you know why not?
I don't know why. They've tried. What they do is I guess, this spontaneous, and she doesn't respond very well to that. So they've
Okay, so
tried.
when you say she doesn't respond very well to that, she's probably getting agitated or combative or breathes against the ventilator.
No, she can't breathe at all. That's what happens. They try it for a few seconds, for a few minutes, and they said they try a little bit every day, but it
Okay.
doesn't work.
Okay. Do you know if your mom had any spontaneous breathing trials at all in this period since she's been ventilated?
She's had it. I've talked to her respiratory therapist, and he says that every day they make an attempt. Now, I don't know what's been done recently.
Okay. And how is she going with those attempts?
They hasn't been successful.
Okay. When you see your mom every day?
Yes, I do. Twice a day.
Right. So when you see her and you talk to her, is she opening eyes?
Yes, occasionally. She flutters her eyes, and she knows that I'm there. She recognizes my father's voice. She recognizes my voice. And so, yeah.
If you hold her hand and you ask her to squeeze your hand, can she do that?
Not really. Not really.
Okay. I do believe, given the timelines here, Victoria, I do believe your dad needs to give consent to a trach as quickly as possible to get rid of the sedation.
Okay.
When you look at some studies, every day you keep someone in an induced coma, the deconditioning is, there are some studies out there, by how much your muscles reduce every day, and I do believe it is absolutely critical to give her a trach in this situation. Now, I would hold off, if I was you, on a PEG tube. She's perfectly fine with a nasogastric tube for nutrition. But I do believe you have no time to waste here to give consent to a tracheostomy. I would imagine they've been pressuring you for that.
Yeah.
Yeah, I can see that. Yeah.
And I think and I think my dad has been on the fence about it because of this hospice, and he says no. He says, "What am I going to do that and dismantle?"
But they won't take her to hospice with the trach. They won't, because what a trach does, if anything, it buys her time to get off the ventilator. I don't see a trach as a vehicle to get patients to hospice. If they wanted to take her to hospice, they would say, let's take the breathing tube out and put her to hospice. That would be the approach. They would most likely be
No, they didn't say that.
Right. I don't see the connection between a trach and hospice. I don't see that connection.
Okay. So the trach buys more time to get her off the ventilator. Is that what you're saying?
Absolutely. But more importantly, it'll get rid of the sedation and she can wake up.
Okay.
Right. But what you should do is you should ask them what's next once she has a trach. You should absolutely ask them for that and see what they say.
Okay.
Right? And they probably won't like you not giving consent to a PEG tube. And I don't know whether she needs a PEG tube down the line or not. I couldn't tell you. A lot of it depends on, does she have a chance to get off the ventilator? Does she have a chance to get rid of the trach eventually? But for now, she can have a nasogastric tube. You don't need to rush into giving consent to a PEG tube.
Okay. So they call that a nasal. What did you mention that again? A nasal.
A nasogastric tube. I'll type it here into the chat pad so you can actually see that nasogastric tube. I'll type it in here so you can see that.
Oh, okay. Okay. Yep. I see it.
Yeah. Yes. Does your mom have an advanced care plan?
Yes.
And what does that say?
Well, it says a lot of things. Well, it certainly makes my dad the healthcare
The
proxy
decision maker, yeah.
decision maker. She never wanted to be hooked up to a machine if she felt that she was in a vegetative state. And that's the picture that they have presented, is she's in a vegetative state. And I said, well, could you explain to me what a vegetative state is? They had difficulty explaining it. And finally I looked it up in Mosby, and I got the and I said, she's not in a vegetative state.
Well, if anything, she's in an induced vegetative state.
Right.
So here's the thing, Victoria. If she has a trach and they stop the sedation, I would hope she'll wake up quickly.
Mm-hmm.
So then they will stop talking about her being in a vegetative state, I would hope.
Mm-hmm.
Here is another risk, Victoria, if she stays in an induced coma for any longer. So one of the risks in an induced coma is, it's a reasonably small risk, but it's still a risk. If she, for example, had a stroke or some seizures, it'll be very difficult to pick up on it because she's in an induced coma.
Yeah, one of the things that they did is they did an EEG to see if she was having any seizures, and it did not, none at this point.
Okay. But I do believe, Victoria, if
Yes.
you've watched my videos, I'm the eternal optimist. However, your mom has been ventilated with a breathing tube for too long, so that the side effects from that, I believe, are way more negative than moving forward with a tracheostomy.
Okay.
And I don't think you have any time to waste here.
Okay.
And especially if they are, but the only thing that I will say, get them to put their cards on the table. So here is the worst case scenario that I can see with a trach. You give consent to a trach, and the next day they want to send her out to an LTAC or back to a skilled nursing facility. That's actually the worst case scenario here. Yeah. One way to avoid that is to not give consent to a PEG tube. There's no guarantee they can't send her out with a nasogastric tube, but the chances are much less likely they can send her out. So, and then you can always give consent to a PEG next week if you think that's the right thing to do. But for now, I wouldn't, because that might things slow down, because as much as I say a tracheostomy is the right thing to do here, their goal is to send her out as quickly as possible.
Yes, of course. That's exactly, and we knew that going in. So long term, what did you say? Aftercare. Yeah, long term.
Aftercare. And nothing should stop them from trying to wean her off the ventilator the minute she has a tracheostomy. Nothing should stop them starting to wean her off, right? Now, I've made some notes. You haven't mentioned anything about your mom having a pneumonia. Does she have a pneumonia?
Right now, she's been diagnosed.
She has?
Yes, right now. That's what the tests have shown. We're not sure. The doctor wasn't sure if it was MRSA. The blood cultures have gone out. She's currently on vancomycin and cefepime at this point.
Okay.
But there's a UTI. There's a UTI infection.
Okay, so not a pneumonia as far as you're aware.
He thought it might be pneumonia today. This is what he said to me.
If you have access to my chart, they would have done a chest X-ray.
Yes, they did. They did a chest X-ray.
And what does the chest X-ray report say? If she has a pneumonia, it would most likely be in the chest X-ray report.
Okay, I can pull that up right now as we speak. Hold on a minute now. Let's see. There was a chest X-ray. I think that was done yesterday. Let's see. Let me check. I got this right. 23rd. I know a chest X-ray was done.
They would have definitely. They would have.
Yeah, on the 24th they did it. The impression was that they talked about hazy opacities in the right mid and lower left lung. Findings likely represent infectious inflammatory process. Central vascular congestion with probable superimposed edema. Moderate right and small left pleural effusions.
Yeah.
Reevaluate for pneumonia fevers.
Right. Okay. Pneumonia. Did you say pneumonia fevers?
That's what they said, that they wanted to reevaluate.
Right. Okay.
The findings was they talked about the endotracheal tubes. The lungs are hypoexpanded, hazy bilblasier opacities, mildly increased compared to prior. This is one that they did on December 12th. Moderate right and small and moderate right and small left pleural effusions. No pleural, no neurothorax. PAP.
Oh, no pneumothorax. No pneumothorax. Yeah. Okay. Good. Good.
Central vascular prominence similar to prior. The cardio media distal silhouette is similar to prior. No acute osseous abnormalities. And she has some degenerative changes in the shoulders.
Sure. Look, it doesn't spell out pneumonia, but it does say about a potentially change in an inflammatory process, which could be a pneumonia. It also talks about hazy opacities. That could be a pneumonia, but it doesn't actually say that.
Mm-hmm.
Right.
Right.
Did they mention to you the risk of ventilator-associated pneumonia? Have they mentioned anything there?
That was one of the things that they talked about, but they didn't get into great detail. This was when they did the scare tactics in the family meeting.
So a ventilator-associated pneumonia is the risk for that is much higher if someone is on a breathing tube instead of a tracheostomy, right?
Mm-hmm.
It's another reason why she should have a tracheostomy. The quicker, the better.
Okay. All right.
I would really like to leave you with that. With what you've shared with me, unless there's anything else that I'm not aware of, I would suggest get your dad to give consent, because at the moment you're not helping your mom moving forward.
Okay.
The deconditioning is real in an induced coma.
Okay. Well, we'll have the conversation with the doctor on Wednesday.
Have the conversation with the doctor on Wednesday.
Yeah, and then I'll
I tell you something else, especially since they mentioned to you that they can do the procedure at the bedside, which is accurate. That's accurate. That's telling me she's still having a window of opportunity to have it done at reasonably low risk, because sometimes they do need to do a tracheostomy in the operating room when there's a higher risk for whatever reason, right? So given that they've highlighted to you, look, we can do this at the bedside, they have, if they are experienced in doing it at the bedside, they'll have it done within 30 to 45 minutes.
That's what the doctor said. That's what he said today to me. There is a skilled surgeon that does it.
Yeah. I would strongly recommend you to do that sooner than later. I don't think you have any time to waste here.
Okay. All right. Thank you. I appreciate it.
It's a great pleasure. All the best to you, Victoria.
Thank you so much. Are you doing these again anytime soon? Any more of these?
Probably next Saturday again. Saturday evening your time, probably 6:30 p.m. Eastern time on Saturday.
Okay, good. Maybe I'll have some more news for you by then.
Yeah.
Thank you so much. I appreciate it.
It's a great pleasure. Nice to talk to you.
Nice to talk to you. Thank you. Bye-bye.
Thank you. Bye. Right. Now, Mariah, thank you so much for your questions here. You're saying, my father's 83 years, had aspiration pneumonia on 21st of November. We have started T-bar, trying to wean off tracheostomy bar, I would think. We're talking about a trach collar here. If he had one 12-hour on a good day, but 4 and 2 hours this weekend, is this progress enough to avoid PEG? Dad has a tracheostomy on the 15th of December, but I have a post-PEG until after Christmas. Oral tube first place on the 5th of December with intubation and then moved to nose. Oh yeah, you're talking about the nasogastric tube. Yeah, okay. So T-bar, you're talking about tracheostomy collar. Okay. Now, if he had one 12-hour good day, but 4 and 2, okay. So he had the tracheostomy on the 15th, and today's the 25th, 10 days in. That sounds like progress to me, Maria. That sounds like progress to me. The question is this. So let's just say he's managing 12 hours on a good day, but then only 4 or 2 hours, during the day on other days. The question is, what ventilation settings is he on when he's not on the trach collar, right? Do you know if he's breathing on CPAP or pressure support, or is he using another ventilation mode? So that's one question. Another question is, if he is he getting mobilized? Is he getting out of bed? Is he conscious? Is he obeying commands? Is he cooperative? Is he calm? What medications is he on? For example, is he getting sedatives? Okay, so he's breathing on CPAP. Great. That's good to know. So that's telling me that, okay, so on CPAP when he's not on the trach collar. So then the other question is he getting out of bed? Is he getting out of bed during the day? Is he getting mobilized? If you could let me know whether he is or he isn't, because that'll give me so much more context, right? I don't necessarily see any correlation between PEG and what he's doing from a ventilation weaning point of view, and I'll tell you in a minute why, right? Today they sent him to SCMV today because he was breathing 30. Oh, you mean probably SIMV. Most likely you mean SIMV, not SCMV. He is not being mobilized. Okay, great. So what you're probably telling me is they probably put him from CPAP onto SIMV. That's how I spell that. I'll just type that into the chat pad. They probably moved him to SIMV, right? Because he was breathing too fast. He was getting exhausted. Okay. Yeah, he was on CPAP, but the nurse had him moved back to full support. Yeah, that makes sense. So let's just quickly go back to the beginning where you said, some days he's doing 12 hours on the trach collar, other days he's doing only 4 hours, and other days he's doing only 2 hours. Now, I argue, if he's not being mobilized, how is his upper body getting stronger if he's not being mobilized, right? How are his breathing muscles getting stronger if he's not sitting up in a chair, right? The best analogy that I can give you here is, if you want to run a marathon, you're not going to run a marathon without training, right? You need to train every day to get ready for a marathon. And it's the same with ventilation weaning. To get off that ventilator, you need to train every day. And that training is only really happening if you get out of bed, if you sit up. Imagine, similar to Victoria's situation a minute ago, imagine you're lying in bed for days and weeks on end. You are deconditioning, your muscles are deconditioning, and it'll be so much harder to get off that ventilator, right? So that's one aspect. The other aspect, Mariah, is what medications is he on? Are they potentially still sedating him? Are they potentially giving him still opiates that have respiratory depression as a side effect? Right? then you are saying we have a PT coming to move his hands only. Well, a PT, a good PT, should be doing breathing exercises, coughing exercises, should be getting him out of bed, full stop. Right? He had Presidex at 0.2, which was taken off today. Keep him off the Presidex, you know, unless he's getting agitated, right? So if he was breathing at 30 breaths per minute and they put him on to SIMV because of that, that could be a sign he's probably not quite ready to wean for more than 12 hours a day. Okay, so how can you overcome that bottleneck? Because clearly it is a bottleneck for your dad at the moment to go from CPAP, SIMV to spontaneous breathing. Clearly that is a bottleneck. Now, from my experience, to overcome that bottleneck is to get him stronger. Okay, how do you get someone stronger that's been deconditioned for weeks on end in ICU? Well, one way to get patients stronger in ICU is, of course, optimize their nutrition, right? And B, mobilize them. Mobilize. And that might start with sitting him up in the bed to begin with, right? Putting him like in a cardiac chair position. Next day, sit him on the edge of the bed maybe for 3-4 minutes. Next day, sit him on the edge of the bed maybe for 5-10 minutes. Next day, sit him in a chair, right? Maybe for 10 minutes, maybe for half an hour. Maybe he gets tired, get him back to bed. Unfortunately, I have nothing else to offer here, but this is hard work. It's hard work for the doctors, for the nurses, for the PT. But that's what it is. It takes hard work. And that's what it is. So you're saying, Mariah, his heart rate goes up to 110 and 120. Is that because of pain? Is it because he's potentially brewing an infection? Is it because he's potentially breathing too fast and he's getting exhausted, right? And is his heart rate going back once he's back on the ventilator, right? That's the question to me. Blood pressure remains stable, but not heart rate. Another reason why his heart rate might go up is he anxious, potentially, right? But Mariah, and this is for anyone watching this, I am so frustrated when I'm hearing that ICUs are not mobilizing patients. I'm so frustrated. Heart rate is still pretty high when on the ventilator. So, okay, that could mean he might be anxious, right? He could also be psychologically dependent on the ventilator. Now it might not even be real. It might just be he's psychologically dependent on the ventilator. Another reason why patients might have a high heart rate is they might be dehydrated. Ask them whether they think he's dehydrated, because then the heart compensates for lack of fluids. Okay, but I can't tell you how frustrated I am that ICUs are too lazy, too complacent to start mobilizing patients. I can't believe that. For anyone watching this, if you have a family member in intensive care, your loved one needs to get mobilized as quickly as possible. Now, the exception here is, there are some exceptions to that. Mariah, you haven't mentioned, if your dad has any fractures, if your dad is awaiting surgery because he's got fractures, unlikely he can get mobilized, okay? But you haven't mentioned anything like that. If a patient is hemodynamically unstable, they are on inotropes, vasopressors, their blood pressure fluctuates, goes up and down, their heart rate goes up and down by too much, yes, you can't mobilize. But your dad with a heart rate of 110 or 120, he should be able to get mobilized, right? Dialysis should not stop him from getting mobilized. No fractures, It is so frustrating. I'm probably a very old school ICU nurse. One thing they drummed into us when I did my training in the late 1990s was you have to mobilize patients. As soon as you can get patients out of bed, get them out of bed. Right? And I have nothing to add to that because it works. It works. I don't know why families in intensive care think that their loved ones can get off a ventilator without them having to do any work. And the work means getting out of bed. It mainly means work for the nurses and for the PT and for the RT, right? But if that can be done, everything will change. You will see that everything will change over time, not in a hurry, not in a hurry. Now, Mariah, you haven't shared with me where you are. I presume you are in the US, but you haven't shared your location with me. If you can just highlight to me whether you're in the US or not. Because if you're in the US, you're facing another challenge altogether. In the US, the ICU wants to send your dad to LTAC as quickly as possible. And the only way they can achieve that is by doing a trach and a peg. Because that's their ultimate goal. They're not keen on mobilizing. They have no interest in mobilizing. They say, oh, well, let's do a trach and a peg. Let's send your dad to LTAC and they will take care of the weaning part. Well, unfortunately, from my experience, nothing could be further from the truth. Yes, you're in the US, you're in LA. Yeah. So nothing could be further from the truth, unfortunately, from my experience, But in the meantime, Mariah, you need to keep the pressure on. It sounds to me like your dad is actually halfway there. He's halfway there, but they need to take the next steps with him. It's not unusual that patients bounce back and need to go back on the ventilator. It's nothing unusual, but he can only overcome that bottleneck probably by getting mobilized. I hope that helps, Mariah. You are already in an LTAC, and they are already telling me even there they keep you for 3 weeks. Yeah, I see. You're in Kindred. I see. Yes, you are under pressure because after 3-4 weeks, they want to send your dad to a skilled nursing facility. Then he'll go from bad to worse. Yes, I can see that. Yeah, you are under a bit of pressure there. But don't be discouraged because I really believe he's halfway there. Don't be discouraged. And what you can do if he's if he's in LTAC, he should be mobilized anyway, but they're not doing that. I get it. Here's another tip. If you're running out of time there, but he's making progress, well, you might have to do an appeal because it sounds to me like he's halfway there. And if he's halfway there, then, that's a good thing. That's a good thing. Right. Hey, Tom, really nice to see you here, and Merry Christmas to you and your family. Hi, Patrick. What's been your experience with Botox injections to manage excessive oral secretions? Our son has now been diagnosed with ALS on top of everything else. I'm very sorry to hear that, Tom. Good experience with Botox injection to manage excessive oral secretions. Some of our clients have that with good experience, generally speaking. Other ways to manage that is potentially with atropine drops or potentially with glycopyrrolate. That's another way to manage that. If you haven't tried the atropine and if you haven't tried the glycopyrrolate, then Botox might be the next step. But before you go for a Botox injection, you might try the atropine and the glycopyrrolate and then see if that works and, see how you go. On glyco, yes, on glyco, yeah. But if the glyco is not working, then maybe you can add in some atropine drops. And if the combination isn't working, then go for an injection. Right. And yes, Mariah, you will absolutely need to file an appeal. And if you're already knowing you've got another 3 weeks left or whatever the time frame is, you might file an appeal now so that you are not running out of time by the time they want to send you out. Right. Tom, you're saying on scopolamine patches. Yes, scopolamine patches might help as well. Yes. I think the challenge with the Botox injection, as far as, as much as I've seen it helps, you would need to get your son out of your home as an outpatient appointment, So you might have to go, wherever you need to go to get that done, which it's more work for you. And whoever is looking after your son, it's more work, But I also understand how annoying it is for everyone if he keeps having those excessive secretions. Okay, Look, we're coming close to the hour mark. You can manage an outpatient trip. That's great. That's really great. Yeah, that's really good that you can do that. Yeah. Now, we're coming closer to the hour mark. I do need to wrap this up in a minute. Are there any other questions? I do have time for another quick question. If not, I do want to wrap this up in a minute. Now, takeaway from today's call is, and I've been saying this in my early blog posts 10 years ago, if the question is tracheostomy or no trach, you got to do it within the first day 10 to day 14. You can't be having someone on a ventilator with a breathing tube for months on end, like we've heard from Victoria earlier. That is to the detriment of your loved one. I'm all about avoiding a trach when you can, but not at the expense of not doing a tracheostomy at the right time. Right, that is the takeaway message from me from today's call. Yes to trach in the right circumstances. Okay. Now, really want to thank you for all your questions. Really want to thank Victoria for coming on to the call. Want to thank Mariah for your input. Want to thank Tom for your input. I really hope things are going well for you, Tom. I did get your text message the other day, but unfortunately I couldn't read it for whatever reason. It came up as in hieroglyphs. So I'm glad that you've managed to ask your question here. Yeah, look, want to wrap this up. Once again, Merry Christmas to you and your families. Stay strong over this period. If you have a loved one in ICU, if you have a loved one in LTAC, stay strong. I know it's not easy, but we are here to help. We also have a membership for families of critically ill patients in intensive care, where we answer your question in the membership. You can get access to the membership at intensivecarehotline.com by clicking on the membership link or by going to intensivecaresupport.org directly. I also offer one-on-one consulting and advocacy over the phone, via Skype, via Zoom, via WhatsApp, whichever medium works best for you. I talk to doctors and nurses directly. I ask all the questions that you haven't even considered asking, but you must ask when you have a loved one in intensive care so that you make informed decisions, have peace of mind, control, power, and influence. We also offer medical record reviews in real time if you need a second opinion in real time. We also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are simply suspecting medical negligence. I also represent you in family meetings with intensive care teams if you would like that. I even evaluate with you whether you should even go into a family meeting with intensive care teams, because sometimes you simply shouldn't go and it'll make all the difference. Now, if you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, comment below what you want to see next, and share the video with your friends and families. If you need intensive care at home for your loved one, and if you are in Australia, we're operating all around Australia with intensive care at home. We are NDIS accredited, we are TAC approved, we are iCare approved in New South Wales, NIISQ in Queensland, DVA around the country. We also have received funding from public hospitals, departments of health, and private health insurances. Please reach out to us. But even if you're in the US and you need intensive care at home, please reach out to us as well. The same in the UK. I believe we can put you on the right track and potentially also hire you some private nurses in those countries. Thank you so much for watching. Once again, Merry Christmas, and I will talk to you very soon. Take care for now.